I'm Dr. Tarek Mouhieddine, and I'm an instructor in medicine at the Dana-Farber Cancer Institute. And I'm here today at IMS 2025, where I presented my work on baseline and longitudinal inflammation and immune composition of myeloma patients who are receiving bispecific antibodies. And in our study, we basically looked into two main variables that we think can be predictive of treatment outcomes for those patients. And we wanted to pick variables that are clinically available, widely available, cost-effective, and easily accessible so that patients all over the world and in any clinic can have access to these simple blood tests and could, to a certain extent, help in predicting how they're going to do when they start treatment with a bispecific antibody. And in order to look into that and see if we're able to achieve this goal, we looked at our patient population at Mount Sinai. We had 325 multiple myeloma patients, and they all received a bispecific antibody, whether it was a BCMA, GPRC5D, FCRH5, we put them all together. The target didn't really matter. And we looked at the two main variables that we looked at were ferritin and absolute lymphocyte count. So ferritin is normally a protein that we look for to assess how much iron somebody has. However, it does also serve as a marker of inflammation in the body. And we know with inflammation, it can be immunosuppressive and it can basically affect that treatment efficacy, and specifically bispecifics and even CAR T cells. Other studies have shown that it can predict worse outcomes for CAR T cells. The other one was absolute lymphocyte count, and that basically tells us how many lymphocytes, and what we care about are T cells specifically, we have within a unit of volume of blood. So the higher the number, the more T cells we expect you to have. And we believe that the more T cells you have, the better the responses will be to bispecific antibodies. Because if you think about it, if we have more T cells, there's going to be a bigger army to fight the myeloma cells. The lower the T cell count, the smaller the army, and the less likely you're going to have a good response against myeloma. And what we essentially found was patients who had high ferritin at baseline before even starting the bispecific, they had a much shorter progression-free survival, unfortunately. And this biologically made sense because it means there's more inflammation in the bone marrow and there's immunosuppression as a result of inflammation. And in addition to that, not only does baseline levels matter, but also how things change over time. So we looked at all these patients and how the ferritin value changed over time. And we saw three different patterns, some with ferritin that quickly starts going down as soon as you start treatment, some with mildly elevated ferritin throughout treatment, and some with a ferritin level that just keeps shooting up. And we found that those with the ferritin that goes down, those performed the best. They had a very long progression-free survival, they had deep responses and durable, while those who had mildly chronically elevated ferritin did it was intermediate, somewhere in the middle, and then those with the high ferritin over time unfortunately did the worst. That very short progression-free survival, and the depth of response wasn't that good. In order to try to understand what happened there, we used a technology called site-seq. And what that essentially means is we took samples that patients donated from peripheral blood and from bone marrow, and we separated them into single cells, and that gives us a better visualization of the cellular makeup of each patient and what each cell is doing or what it's producing or presenting on the surface. And we saw that patients with high ferritin had more macrophages and monocytes in their bone marrow. And those cells do have other functions in the immune system, but they do tend to be high in states of inflammation. So basically, high ferritin, high inflammation, we saw more monocytes. It made sense. In addition to that, patients with low ferritin, they actually had more T cells and more NK cells, which is also another important partner in the immune system. So this basically tells us that ferritin can be a good marker that can predict how you're going to do with bispecifics, but also it gave us insight into the immune composition that happens in patients who don't respond as well. And it's giving us, or paving the road actually for the future, to see if we should be creating new drug combinations that can not only target myeloma, but also target the other players in the immune system, like macrophages and NK cells, which seem to have a role in how people respond to these therapies. And then on the other hand, we have the absolute lymphocyte count, which logically also makes sense to look at because, like I said, it's like an army. And then those with low absolute lymphocyte count, specifically below 0.9, unfortunately had a much shorter progression-free survival, while those above that number had a much higher progression-free survival. And in addition to that, we did see 3 different trends over time after you start the bispecifics, and those that did the best were those who had an ALC that just kept going up over time, which means that the amount of T cells or fighters against myeloma was very good. It was steady and was consistently high, which means that it was always able to fight off the myeloma, compared to the curve that where the ALC just went down over time, meaning you didn't have enough T cells to fight the myeloma, and those patients unfortunately had a short response to treatment. So in the end, putting these together, we see that these 2 variables, which are readily available to anyone, they are blood tests and pretty inexpensive, can be predictive. They have a predictive and prognostic value for myeloma patients who are undergoing these treatments. And while at this point this doesn't change practice, like I'm not going to say that, if you have high ferritin, you shouldn't take a bispecific. It does, to a certain extent, give us an idea about what to expect and what we should be planning for as a next step. And to add on top of this, we are in the process of creating an online accessible calculator for clinicians and patients, where we have several values where people can enter their data, a few blood tests that we looked into, and some even imaging results, where put together it creates a score for you that tells you or estimates how long you're going to respond to a bispecific antibody. So we're still tweaking this model. It's almost there, but once it's ready, we're going to make it accessible to everyone, so both clinicians and patients can use the model. And while it won't tell you don't treat versus treat, it's going to just at least give you an expectation of what's going to happen over time with a patient once they start any of the bispecifics.